If the liver cannot drain, it drowns in its own blood.
Wow. That is a visceral way to start. It's a really terrifying image.
It is, isn't it? But it's also just so perfect. It grabs you immediately because it sounds like something out of a horror novel, you know?
Yeah, like something Edgar Allan Poe would come up with if he'd gone to medical school.
Exactly. But it's not fiction. It's pure physiology. And it is the absolute defining feature of the topic we're tackling today, Budd-Chiari syndrome.
It's such a vivid picture of really a mechanical failure. And, while the name Budd-Chiari, it might sound like some, super niche, dusty topic you'd find in a textbook footnote.
Or something you cram for an exam and then immediately forget.
Right. But it's actually, and I mean this, it is a gold mine.
A gold mine. Okay, you're going to have to sell me on that one. Usually, when we talked about syndromes named after a couple of dead guys from the 1800s, it's just a long list of symptoms to memorize.
No, this is totally different. It's a gold mine of physiological logic.
Yeah.
It's one of those rare topics where once you really get the mechanics of it,
Yeah.
I mean, the actual plumbing, a whole bunch of other things in medicine just click into place.
Okay. I'm with you.
And that's why you see it come up again and again in big medical exams, the USMLE, NEET, the MRCS. Examiners love this topic.
Why? Just because it's obscure?
Not at all. It's because you can't fake your way through it. It's not about memorizing a list.
It's about understanding the system. You have to understand the plumbing, not just that the faucet is leaky.
Precisely. If you just try to rote memorize the symptoms of Budd-Chiari, you're going to get tripped up. You'll confuse it with cirrhosis or heart failure or something else. But if you understand the plumbing, the pressure, the flow, the blockage, it all just becomes, well, intuitive.
Right.
You stop memorizing and you start deducing.
I love that. Stop memorizing, start deduce. Okay, so let's get the foundation right. What at its core are we dealing with here?
At its most fundamental level, Budd-Chiari syndrome is an obstruction of hepatic venous outflow.
Okay, let's break that down. Hepatic venous outflow. So we're talking about the drain pipes.
Yes.
Not the supply lines.
That is the single most critical distinction. This is not an inflow problem. We're not talking about blood struggling to get into the liver. We are talking about blood that's already been through the system. It's done its job, been cleaned by the liver cells, and now it just needs to leave. It needs to get back to the heart.
So the exit is jammed.
Welded shut in some cases. And the blockage can be anywhere from the tiniest little hepatic venules deep inside the liver all the way up to the big junction where the inferior vena cava, the IVC, plugs into the right atrium of the heart.
It's a classic analogy. If the drain is clogged, the sink is going to overflow.
And the sink, in this case, is your liver, and the water is blood. And that brings us right back to that quote.
If the liver cannot drain, it drowns in its own blood. Okay, so our mission for this deep dive is to get past the facts and figures. We want to understand the mechanical logic of the liver. We want to know why it acts the way it does under this specific kind of stress.
We're chasing the why. Why does the liver end up looking like a nutmeg? It's a bizarre description, right?
It is.
Why does one part of the liver just give up and shrink while another part weirdly gets bigger? And why does the body desperately try to, build its own bypass roads, its own alternative plumbing?
I love that idea. The body as an emergency engineer. So let's get into it. Section 1. The plumbing problem. To get why the clog is so bad, we have to understand the normal layout of the pipes. Because the liver isn't just a big bloody sponge, is it? It's got a very specific architecture.
A very elegant architecture. So in a healthy body, the liver is this massive processing plant. Blood comes in, gets processed, and then it has to get out. The standard drainage system, it relies on 3 main veins.
Okay.
The right hepatic vein, the middle hepatic vein, and the left hepatic vein.
Right, middle, and left. Simple enough. It's like a 3-lane highway leading out of the city.
That is a perfect analogy. These 3 main veins collect all that processed blood and they dump it into the inferior vena cava, the IVC. And that's like the main interstate, taking all that traffic straight up to the heart.
And normally it's smooth sailing, no traffic jams.
No traffic jams. But here's where things get really, really interesting. Because nature, for whatever reason, built a back door. Or maybe, depending on how you look at it, a kind of VIP escape route.
This is the aha moment.
This is the aha moment. This is where we introduce the hero of the story, the Caudate lobe.
The Caudate lobe. It sounds like a secret society or a spell from Harry Potter, but it's a real piece of anatomy.
A very specific piece. It's a segment of the liver, usually tucked away in the back segment if you're into the formal classifications. And the key thing is, it's anatomically unique. It's almost like a separate little organ that's been fused onto the back of the main liver.
Fused on. How so?
Well, while the rest of the liver, the big right and left lobes, are all depending on those three main highway lanes to drain, the caudate lobe has its own private exit ramp.
It's got an easy pass while everyone else is stuck in traffic.
It absolutely does. It has its own set of independent small veins. They're sometimes called the Spigelian veins, and they drain directly into the IDC. They don't use the main hepatic veins at all. They just bypass them entirely.
So it has a direct line to the interstate.
It does.
Okay, let's play this out then. So in Budd-Chiari, there's a massive pileup. The right, middle, and left hepatic veins are completely blocked. There's a clot. The highway is shut down.
Concrete barriers, police tape, the works, total shutdown. So all that blood in the right and left lobes has nowhere to go. The liver becomes incredibly congested. It's literally drowning.
And the pressure just builds and builds.
Skyrockets. And when the pressure gets that high, fresh blood can't get in because the old blood can't get out. So oxygen delivery fails, and the liver cells, they just start to die.
And basic biology tells us that a tissue that's under that much stress, that can't function, it eventually atrophies, it shrinks.
Precisely. The main bulk of the liver, the right and left lobes, they just start to wither away. But all the while, the caudate lobe is sitting there with its private driveway.
It's watching the chaos from its balcony, sipping a martini.
Pretty much. I mean, its drainage is totally fine. Its little veins plug directly into the IVC, usually below or just separate from where the main blockage is. So not only does it keep working, it actually goes into overdrive.
Why overdrive? Is the body sending it some kind of signal?
An urgent one. The body senses the liver is failing. It knows it's losing function. So it floods the system with growth factors, things like hepatocyte growth factor. These signals are basically screaming, grow, we need more liver function now.
And the right and left lobes can hear the screams, but they're suffocating. They can't do anything.
They can't respond. But the caudate lobe, it's got great blood flow, gets the signal, and it has all the oxygen and nutrients it needs to act on that signal.
So it's the only part of the factory that's still operational, so the boss just dumps all the extra work on it.
And what happens to any muscle or any organ that's forced to work overtime?
It gets bigger. It hypertrophies.
Exactly. So what you see on a CT scan in a patient with Budd-Chiari is this really bizarre picture. You see a shrunken, dying liver on the outside, but then this one massive bulging lobe right in the middle.
That's the caudate lobe hypertrophy, and this is what doctors call a pathognomonic sign, right?
Pathognomonic. It's a great word. It means if you see this, you almost certainly have your diagnosis. It's not a clue. It's a smoking gun.
And that's why it's a favorite question in, surgery exams.
Oh, absolutely. Because it proves you're not just memorizing lists of symptoms for liver disease. It proves you understand the anatomy. You get why the caudate lobe is special.
If you're in an oral exam and they show you that scan and you say,
confidently say, that is compensatory hypertrophy of the caudate lobe because it drains directly into the IVC, bypassing the main venous obstruction, you've just nailed it. You've passed that station.
you drop the mic.
You absolutely win the room. It's that level of detail that shows you understand the why.
So we've got the plumbing failure, we've got the heroic caudate lobe, but let's rewind. Why did the clog happen in the first place? Veins don't just, decide to close up shop on a whim. What's causing this massive blockage?
Right. And that brings us to the root causes. And generally, we split them into primary and secondary. Primary means the problem is intrinsic to the blood itself. Secondary means something on the outside is squishing the vein shut.
Let's start with primary. So this is a clot forming inside the vein. Intrinsic thrombosis.
Correct. The most common cause of Budd-Chiari by far is thrombosis that's driven by what we call a hypercoagulable state. Basically, the blood is just too sticky. It's too prone to clotting.
And to help us remember all these sticky blood conditions, the source material gives us a classic mnemonic. PTCH. P-A-T-C-H.
It's a good one. It covers the big ones.
Okay, let's break it down. P is for?
Polycythaemia vera.
And the source says this is the single most common cause.
It is. Polycythemia vera is a myeloproliferative disorder, which is a fancy way of saying your bone marrow goes crazy. It makes way too many red blood cells.
But why does that cause a clot specifically in a big vein like the one in the liver? Why not somewhere else?
Think about viscosity. If you have way too many red blood cells, your blood gets thick. It literally turns into sludge. Now, your arteries, they're high-pressure pipes. They can push sludge through, but your veins...
They're low pressure. They're lazy rivers.
Exactly. And if you fill a lazy river with mud...
It's going to back up and stop moving.
And what does stagnant blood do?
It clots.
That's the rule. Stagnant blood always clots.
And this is where modern medicine adds a new layer. The source brings up the JAK2 mutation.
Yes, this is huge. If you're practicing today or taking a modern exam, they won't just want to hear polycythemia. They'll expect you to mention the JAK2 mutation. It's a specific genetic glitch, an on switch for cell growth that gets stuck in the on position. Testing for it is just standard of care now if you suspect Budd-Chiari.
Okay, so key is for polycythemia, sludge blood. What about A?
A is for antiphospholipid syndrome. This is an autoimmune problem. Your immune system starts attacking proteins in your blood, and for complicated reasons, that makes you much more likely to form clots.
So your own body's working against you. And T?
T is for thrombophilia. And this is really a catch-all term for various genetic factors. The famous ones are factor V Leiden mutation or protein C and S deficiency.
Right.
These are just little glitches in your body's natural clotting and unclotting system. Normally, protein C and S are the brakes on the clotting process if you don't have enough of them.
You've got no brakes. The clotting just keeps going.
No brakes on the clotting train.
Okay, moving to C. This one feels like it's relevant to a huge number of people.
C is for contraceptive pill and also for pregnancy.
Hormones.
Hormones, absolutely. Estrogen specifically creates a prothrombotic state. It encourages the liver to churn out more clotting factors. Now, for most healthy people, this is not a problem at all. But if you have an underlying undiagnosed issue, like you have factor V Leiden and you don't know it, and then you start taking an oral contraceptive,
That's the tipping point.
it can be the straw that breaks the camel's back. The combination of factors pushes you over the edge into forming a massive clot.
Wow. And finally, H in PTCH.
IC stands for other hematological disorders. The big one to know here is paroxysmal nocturnal hemoglobinuria, or PNH. It's rare, but it's famous for causing clots in really weird places, like the veins in the abdomen.
So that's our PTCH mnemonic, a really good checklist. If you find Budd-Chiari, you have to go hunting for one of these underlying problems.
You absolutely have to, because you can fix the clot, but if you don't treat the sticky blood, you're just going to form another one. You have to treat the root cause.
Right, so those are the primary causes, where the blood itself is the villain. What about the secondary causes? This is where something is crushing the pipe from the outside.
Exactly, or in some cases, invading it. And the most common culprits here are tumors.
Which ones we're talking about?
Hepatocellular carcinoma, so liver cancer, is the big one. It has a nasty tendency to not just push on blood vessels, but to actually grow into them. We call it a tumor thrombus. It's not a blood clot. It's a solid plug of cancer cells growing up the vein.
That's terrifying.
It is. And renal cell carcinoma, kidney cancer, can do the same thing. It can grow right up the renal vein and into the IVC, blocking everything.
Okay, but there's one more really specific cause mentioned in the source that sounds different. The IVC web.
Ah, yes. This is a fascinating piece of medical geography. It's also called membranous obstruction of the IVC, or MOVC.
Yeah.
And it's basically what it sounds like, a fibrous web or a membrane that goes inside the vena cava.
Like a net.
Exactly, like a net that slows down blood flow and causes it to back up.
And the source points out that this has a very specific geographic pattern.
It does. While thrombosis, the clotting, is the main cause in the West, this IVC web is much more common in patients from India, Japan, and parts of Africa. The thinking is that it might be related to old low-grade infections or maybe nutritional factors, but it's still debated. The bottom line is, if you're practicing in those regions, this has to be high on your list of possibilities.
And it's not just a benign little web, right? There are other consequences.
No, it's a serious problem.
Ah.
That chronic stasis and irritation from the web significantly increases the risk of developing hepatocellular carcinoma. So if you find an IVC web, that patient needs to be screened for liver cancer regularly.
Okay, so we have the anatomy, we have the causes. Now let's get visual. Section 3. What does this actually look like? If I'm a pathologist who gets to see this liver, or a radiologist looking at a scan, what am I seeing?
You are seeing one of the most vivid, classic descriptions in all of pathology, the nutmeg liver.
I've always loved that term, nutmeg liver. It sounds so culinary, almost cozy. But the reality is obviously anything but.
It's pretty grotesque when you understand the mechanism, yeah. But the visual is spot on. If you take a nutmeg kernel and slice it in half, you see that modeled pattern, right? Alternating dark and light areas.
Right.
That is exactly what the liver looks like in Budd-Chiari.
Okay, but let's get to the why. Why a spice? Why isn't it just all red and congested or all pale and dead?
It all comes down to the microscopic architecture of the liver, what we call the zonal architecture. So we have to zoom way in to the level of the liver lobule, Imagine the liver is made up of millions and millions of tiny hexagons.
Okay, hexagons, like a honeycomb.
Perfect. At the corners of each hexagon, you have the blood supply coming in. The portal triad, that's fresh, oxygenated blood. Then, in the dead center of the hexagon, you have the drain pipe, the central vein.
So blood flows from the outside corners in towards the central drain.
Exactly. And as that blood flows past all the liver cells in the hexagon, they do their job, and they use up the oxygen. So by the time the blood gets to the center, to the drain, it has a lot less oxygen than when it started. The cells right around that central drain, we call them zone 3 cells, they are always living on the edge, metabolically speaking.
Okay, so zone 3 is in the center, near the drain, low on oxygen. And zone 1 is on the periphery, near the fresh supply, rich with oxygen.
You got it. Now let's apply Budd-Chiari. We block the drain.
So the pressure backs up.
It backs up from the center, outwards.
Yeah.
The central vein and the area around it, zone 3, it gets massively congested with stagnant blood. And because that blood isn't moving, no new oxygen is getting in. So those vulnerable zone 3 cells, they die. They undergo necrosis and they get filled with dark, deoxygenated blood.
So that's the dark red part.
That's the dark red part. But the cells on the outside, in zone 1.
They're still close to the fresh blood supply coming in from the corners.
Exactly. They might be feeling the pressure, but they're still getting enough oxygen to survive. So they stay a relatively healthy yellowish tan color.
So you end up with this repeating pattern. A dark red dead center surrounded by a ring of lighter, healthier tissue, dark center, light ring, over and over again, millions of times.
And that's what creates the mottled, speckled appearance of a cut nutmeg. It is literally a geographic map of congestion and oxygen starvation across the liver.
So is this pattern unique to Budd-Chiari? If I see a nutmeg liver, can I just sign the case out?
No, and that is a really key differential. Nutmeg liver is a sign of severe hepatic congestion. You see the exact same picture in severe right heart failure.
Oh, right. Because in right heart failure, the heart's right side is too weak to pump blood forward, so blood backs up into the IVC and then down into the liver.
Exactly. The end result for the liver is the same, congestion. The liver doesn't care if the dam is at the hepatic vein or further upstream at the heart. It just knows it can't drain.
Got it. Okay, so that's the pathology. But what about the patient? They're not walking into the clinic saying, "Doc, I think I have a nutmeg liver." What are they complaining about?
Well, the classic textbook triad is abdominal pain, ascites, which is that fluid buildup in the abdomen, and hepatomegaly, an enlarged, swollen liver.
Pain, fluid, big liver.
That's the triad. But as the source material points out, reality can be a lot messier. You can have a very acute presentation, which is dramatic, sudden, massive ascites, jaundice. The liver is failing, and it's failing fast.
And then there's fulminant. That sounds even worse.
Fulminant is a catastrophe. That's acute liver failure plus encephalopathy. Confusion, altered mental state, even coma. The patient is crashing hard.
But the most common presentation is actually chronic, right?
Yeah, the most common is chronic. It's insidious. It just kind of creeps up over months or even years. The patient might just have some vague abdominal discomfort, maybe some swollen legs. The body has been compensating for a while, growing some of those collateral veins, just trying to keep things going.
Speaking of collateral veins, the source mentions a really cool clinical sign that I think is fantastic, the back veins sign.
This is a brilliant piece of old-school bedside medicine. In an age of billion-dollar scanners, this is something you can just see with your own eyes. And it can help you distinguish Budd-Chiari from its main mimic, cirrhosis.
So in cirrhosis, the classic sign is caput medusa.
Right. In cirrhosis, the main blockage is in the portal vein, before the liver. So the blood tries to find a detour back to the heart, and one of those routes is through the old umbilical veins around the belly button. So you get these big, snaky veins radiating out from the navel. Looks like the head of Medusa.
But in Budd-Chiari, the blockage is after the liver, in the hepatic veins or the IVC. The problem is in a different location.
A totally different location. The IVC is the main highway that runs at the back of the abdomen. So if that highway is closed, the blood has to find a detour around it. It can't really use the front route, so it uses the back. It diverts through the veins on the back and on the flanks, the lumbar veins.
So instead of seeing veins popping out on the belly, you see these prominent veins on the patient's back and sides.
Exactly. And if you're really slick, you can check the direction of flow. You press on the vein, empty it, and see which way it fills. In Budd-Chiari, the flow in these abdominal collaterals is upward, trying to get around the block to the heart. But in the legs, the flow might be stagnant or even downward because it can't get up past the obstruction.
That's incredible. It's a living roadmap of the body's detour.
It is. And spotting those posterior collaterals, that's a Viva Gold kind of finding. It shows you're thinking about the three-dimensional anatomy of the venous system.
All right, so we've done our physical exam, we've spotted the back veins, we have a strong suspicion. Now we need to prove it. Section 4, the detective work. What's our first line test?
Always start with an ultrasound with Doppler. It's cheap, it's non-invasive, it's quick, and it tells you about blood flow, which is the whole issue here.
What are we actually looking for on the screen?
First, you're looking for what's not there. You should see flow in the hepatic veins. If you see silence, if the machine isn't picking up a signal, that's a huge red flag. Sometimes you'll even see flow going the wrong way, a reversal of flow.
The blood is trying to escape.
It's trying to go anywhere it can. And the source also mentions the spiderweb collaterals.
Another great name.
It is. Because the main veins are blocked, the body desperately tries to grow these tiny little new vessels to get around the blockage. And on an ultrasound, instead of seeing a nice, clean, single hepatic vein, you see this messy, chaotic tangle of vessels that looks like a spider web. That is classic for Budd-Chiari.
But sometimes the ultrasound is ambiguous. We need a better picture, so we order a CT scan, and here we see something called flip-flop enhancement.
Yes, I love these names too. Flip-flop enhancement is a perfect description of a visual mismatch you see with the contrast dye over time.
Okay, walk me through it. What's happening?
So you inject contrast dye into the patient's arm. It circulates through the heart, into the arteries, and then into the liver. In a normal liver, the whole organ kind of lights up with the dye pretty evenly and pretty quickly.
Makes sense. But in Budd-Chiari?
In Budd-Chiari, the contrast gets delivered to the liver, but it can't drain out of the main lobes because the veins are blocked. So the blood in the contrast dye with it just sits there. It stagnates. The periphery of the liver looks patchy or dark in the early phases of the scan.
But to our hero, the caudate lobe.
The caudate lobe has its private exit ramp. So the blood and contrast flow in and flow out of it perfectly. It enhances really quickly and really brightly.
So you get this flip-flop. The center of the liver, the caudate, is blazing white, and the periphery, the rest of the liver, is dark and mottled.
Exactly. Central, avid enhancement versus peripheral, patchy non-enhancement. That visual mismatch is another one of those pathognomonic signs. You see that on a scan, you can be pretty confident in your diagnosis.
Okay, last piece of detective work. The fluid, the ascites. We put a needle in the patient's belly, we drain some fluid. What does it tell us?
We do something called an ascites analysis. First, we calculate the SAG, the serum ascites albumin gradient. It's a simple subtraction. The albumin level in the blood minus the albumin level in the acidic fluid. In Budd-Chiari, the SAG is high, greater than 1.1.
Which just tells us there's portal hypertension, high pressure. But that's also true for cirrhosis, so how does that help differentiate?
That is the key question. A high SAG just tells you it's a high-pressure problem. It doesn't tell you the cause. The real smoking gun, the thing that separates Budd-Chiari from cirrhosis, is the total protein level in that fluid.
Okay, this is the crucial point. Why is the protein different?
Think about the underlying pathology. In cirrhosis, the liver is scarred and fibrotic. It's like a hard rock. The fluid that gets squeezed out is basically just water being pushed through a very fine filter. It has very little protein in it that we call a transudate, low protein.
But in Budd-Chiari...
In Budd-Chiari, the liver isn't necessarily scarred yet. It's just acutely congested. It's swollen and engorged with blood. The pressure inside the liver's capillaries, the sinusoids, is so high that they get stretched out and leaky. This high pressure forces protein-rich fluid, almost like lymph, to just weep or sweat right off the surface of the liver into the belly.
So the fluid itself has a high GH protein level.
Usually greater than 2.5 grams per deciliter.
Okay.
And that is a massive, massive difference. Low protein in cirrhosis. High protein in Budd-Chiari.
And that one number tells the whole story. One is a scarring problem, the other is a raw pressure problem.
Exactly. It's the difference between a clogged filter and a pipe that's about to burst.
Okay, we've done it. We've cracked the case. We know it's Budd-Chiari. The liver is drowning. So how do we fix the plumbing? This brings us to Section 5, the treatment ladder.
And it really is a ladder, a stepwise approach. You start on the bottom rung and you only climb up if you have to. We could think of it with the mnemonic MATSL, M-A-T-S-L.
All right, step 1, the bottom of the ladder.
M is for medical management. This is the foundation of everything. We've established that the main cause is a clot, so the first thing we have to do is stop the clotting. We start with anticoagulation.
Blood thinners.
Blood thinners. Heparin first because it's fast-acting, and then we bridge them to a long-term pill like warfarin or one of the newer agents. At the same time, we're managing the symptoms diuretics to get rid of the ascites. And crucially, we have to treat the underlying cause, If it's Polycythaemia vera, we treat that. If it's an autoimmune issue, we treat that. If you don't treat the root cause, the clots are just going to come right back.
But sometimes the pills aren't enough. The blockage is too severe. We have to climb the ladder to A.
A is for angioplasty. This is the perfect treatment for those IVC web cases we talked about.
The ones that are more common in India, Japan, and Africa.
Exactly. If the problem is just a thin little membrane blocking the pipe, you don't need a huge operation. A radiologist can go in with a catheter, thread a balloon across the web, and just pop it open.
A simple mechanical fix for a simple mechanical problem?
It's elegant. And it have fantastic long-term results. For that specific cause, it's the first-line treatment.
Okay, but what if it's not a simple web? What if it's a long, hard, organized blood clot? Popping a balloon won't work. We move up to T.
T is for TIP-PS. That stands for transjugular intrahepatic portosystemic shunt.
That is a mouthful. And
Yep.
it sounds like something from a sci-fi movie.
It kind of is. What we're doing is creating an artificial tunnel, a shunt, right through the middle of the liver to bypass the blockage.
Wait, walk me through that again. How do they do that?
Okay, so an interventional radiologist goes in through the jugular vein in your neck. They snake a long wire down into your heart, down through the IVC, and into what's left of your hepatic veins near the liver. Then, and this is the wild part, they take a long needle and they punch it through the wall of that vein, through the liver tissue itself, until they hit a branch of the portal vein on the other side.
They are drilling a subway tunnel inside a living organ.
That's a great way to put it. And once they've created that tunnel, they deploy a metal stent to prop it open. And just like that, you've connected the high-pressure portal system to the low-pressure systemic system, letting all that congested blood escape.
But the source mentions a very important nuance here. A TIP-PS procedure is much harder to do in Budd-Chiari than it is in cirrhosis. Why is that?
Think about your target. In cirrhosis, the hepatic veins are usually wide open. The liver tissue around them is just hard. But in Budd-Chiari, the hepatic vein itself is the problem. It's clotted off, it might be scarred down, it might not even be visible on the x-ray.
So you're trying to land a helicopter, but the landing pad has disappeared into the fog.
Exactly. You're often having to puncture blindly or try to force a needle through a rock-hard chronic clot. The liver is also swollen and mushy, so the texture is all wrong. The technical failure rate is much higher.
So the radiologist is really earning their pay on that one.
They absolutely are. And because of that difficulty, in Budd-Chiari, TIP-PS is often seen as a bridge. It's not the forever fix. It's a way to decompress the liver and keep the patient stable enough to get to a transplant.
It buys you time.
And in a disease this aggressive, time is everything.
Okay. So if TIP-PS fails, or it's just not possible, we have to climb again. We get to S.
S is for a surgical shunt. And the classic one to know for the exams is the mesoatrial shunt.
Mesoatrial. That sounds like major surgery.
It is. This is big, open chest, open abdomen surgery. You are physically taking a graft, a tube, and sewing one end to the superior mesenteric vein, which drains the intestines, and the other end directly to the right atrium of the heart.
Wait, you're bypassing the liver and the IVC completely?
Totally. You are creating a massive detour,
Yeah.
taking blood from the gut and dumping it straight into the heart.
The source notes this is pretty rare now.
It is. TIP-PS and liver transplant are just better options in most cases, but it's still heavily tested on surgical exams because it proves you understand the macroanatomy and the principles of blood flow. It's the ultimate plumbing reroute.
And that brings us to the very top of the ladder.
L. L is for liver transplant. This is the definitive treatment. When the liver is just too damaged, too necrotic, or the underlying problem can't be fixed any other way, you replace the whole engine.
And what are the outcomes like?
They're excellent. 5-year survival is in the range of 70 to 80%. But, and this is a huge but, you have to remember what caused the problem in the first place.
The sticky blood.
The sticky blood.
Yeah.
So even with a brand new liver, the patient's blood is still hypercoagulable. They will almost certainly need lifelong anticoagulation to prevent the new liver's veins from clotting off too.
You've given them a brand new sink, but you still have to make sure you're not pouring sludge down it.
That is the perfect way to think about it. You have to keep the sludge thin.
So that's our Matzah ladder: medical, angioplasty, TIP-PS, shunt, and transplant. A very clear progression.
A clear progression from least invasive to most definitive.
Okay, before we wrap up, let's do what the source calls the synthesis. The rapid comparison. This is for everyone listening who's studying for a board exam or a Viva, the rapid fire round.
This is where you can score some really easy points if you just have the key differentiators locked in. You need to be able to instantly tell Budd-Chiari apart from its main mimics, cirrhosis and right heart failure.
Let's do it. Differentiator number 1, caudate hypertrophy.
Budd-Chiari, yes, absolutely.
Yeah.
Cirrhosis or heart failure, no. That is your single biggest radiological clue. If the caudate is massive, you have to be thinking Budd-Chiari.
Differentiator 2, acidic protein level.
Budd-Chiari, high. Right heart failure, also high because it's also a congestion problem. Cirrhosis, low. That protein level is what separates the congestion diseases from the scarring disease.
Number 3, nutmeg liver.
Budd-Chiari, yes. Right. Heart failure, yes. Cirrhosis, no. Again, nutmeg just means congestion.
And finally, number 4, the pattern of collateral veins.
Budd-Chiari, prominent veins on the back and flanks. Cirrhosis, around the umbilicus, the caput medusae. Heart failure, usually not many prominent collaterals at all.
So if you can just remember 3 things for Budd-Chiari: caudate hypertrophy, high protein ascites, and those posterior collaterals.
You can nail almost any comparison question they throw at you. You have the keys to the kingdom.
It really does demystify it when you break it down like that. It's not some weird random disease. It's just physics and plumbing.
At the end of the day, that's all it is.
Okay, so let's bring it all home. We started with this terrifying image of drowning liver. What's the final integrating concept? If you remember one single thing from this deep dive, what should it be?
The core philosophy, the single unifying idea, is this. Budd-Chiari is fundamentally a problem of venous exit. Everything we've talked about, every single symptom, every diagnostic sign, every single treatment, it all comes back to that one simple mechanical fact.
So why does the caudate grow?
Because it's the only part that has a working exit.
Why do you get a nutmeg liver?
Because the exits of the individual lobules, the central veins, are blocked and congested.
Why is the acidic fluid full of protein?
Because the intense back pressure forces protein-rich fluid to leak out of the liver. It can't exit properly.
And why does the whole mat cell treatment ladder exist?
It's all about creating alternative exits. Whether you're popping a web with a balloon, drilling a tip shunt, or sewing a new pipe to the heart, you're just desperately trying to give that trapped blood a way out.
It's really incredible when you frame it like that. The body as this desperate engineer.
It truly is. I mean, think about the caudate lobe. The main highway is blocked, so the body just starts rerouting all the traffic onto this tiny back road and expanding it. Or those posterior collaterals. It's building new side streets in real time because the interstate is closed.
The liver's attempt to reroute its own drowning. It's just this amazing testament to biological resilience.
It tries its absolute best. It buys us time. And even if it ultimately needs a surgeon to come in and finish the job, the physiological logic is already there. The body is already trying to solve its own plumbing crisis.
That's a fantastic thought to leave everyone with. The next time you're faced with a complex medical puzzle, don't just look at the problem. Look for the exit strategy. Look for where the body is already trying to compensate. The answer is so often written right there in the anatomy itself.
Well said.
That wraps up our deep dive into Budd-Chiari syndrome. We hope you feel a little more like a master plumber and a lot more prepared for whatever comes your way. Thanks for listening.